know.
Getting on the live stream. We have an exciting talk tonight. Thank you all for joining us. So, tonight we are going to be talking about bowel endometriosis, about endometriosis in families and genetic disease. And we have very special guests. We have Dr. Dan Marcus, who is the chair of robotic surgery at Cedars-Sinai Marina del Rey. He's fellowship trained in minimally invasive surgery and specializes in treating endometriosis of the bowel. He also does multi-organ surgery in the abdomen, all different cases. He's a busy guy, and we're lucky to have him join us here today. He also teaches in the fellowship program and residency program at Cedars in LA, and he has been doing endometriosis work on the bowel for over 10 years now, and is very experienced with this. We have Bailey Steves, who is an endometriosis patient and advocate, and who began her journey with a memory of her mom's pain, and led to her own diagnosis through excision surgery. And she and her sister are both here today, who went same day excision surgery in LA, right? And we have a very interesting story with how different the disease can look, even within the same family and with different expectations of how it will look. And we have Devin here, her sister, who's also an advocate and faced unexplained symptoms for years before finding out that her symptoms could be endometriosis. And both sisters had different stories, and we'll hear a lot about that tonight, which is interesting. Um, and we are grateful for both of you for being advocates and helping for early diagnosis and multidisciplinary team care. So, welcome everyone. Today, we're going to talk a little bit more about how common this may be in families and how really, even though, a mom, an aunt, a cousin, a sister may have it, it doesn't mean that the endometriosis will be in the same spots. It doesn't mean that the symptoms will be the same. And one family member may have really painful cycles, and one may have no pain with cycles and just have some bowel symptoms. And so it's very difficult sometimes to even attribute all of it to endometriosis within the same family. And so sometimes it gets missed that way. And it's important to really have these conversations with family members because, it can be kind of overlooked, or sometimes we can hear, oh, everyone in the family always had painful periods. That's normal. It's not endo, it's just part of the family, And so there's a lot of sort of, I would say, misconceptions that happen around endometriosis, and it's important to kind of talk to different family members about their symptoms. And obviously, endometriosis in this case it's not just a pelvic disease, and we're going to be talking about all the different places that endo can happen in and how it can be missed. And we'll let Bailey take it away.
Yeah, I'll give a little bit of background on my story and how I came to seek out surgery for my endometriosis. I think it started for me when I first got my period. I had very painful periods. I think that was like my primary complaint. I remember speaking to my mom, and she had mentioned that she also had very painful periods. So she was able to empathize with me a little bit. But I had also a little bit of GI symptoms. And as the years progressed, as I got older, it got to a point where the pain was so severe that every period I would throw up just from the pain, and it just became a nightmare. I went to my OBGYN, and I had lab work done. I had different ultrasounds done, transvaginal, abdominal. Nothing was found, but I just had the suspicion that, just hearing my mom's complaints, she unfortunately passed when Devin and I were in high school. So I didn't really have her to, really communicate and talk about her full medical history with. But I just remembered in the back of my head that she also had severe periods, and I just knew it wasn't normal. So I kept pushing, and ultimately I decided to get excision surgery to see if I had endometriosis, and then also to determine its severity. I was, they found that I had stage 3 endometriosis. And yeah, that was a shock to me. And especially, my sister also at the time, I kind of left that out. But she also, when I decided to get surgery, was complaining of some pain in some pelvic pain.
Mm.
And I, being the type A older sister I am, started researching more, and I started to research a little bit about the genetic component of endometriosis. So I talked to her and I said, you should get surgery as well. There's a likelihood that you have it. If I'm suspecting I have it, and I suspect that our mom had it as well. So Devin and I had surgery the same day, which was really special to go
Mhm.
through that with her. And our stories and our symptoms are different. And I think it's interesting to discuss, especially as we learn more about this disease. And I'll let Devin maybe discuss what some of those symptoms are for her.
hmm So my endometriosis journey started off in high school. So at the time, I had very heavy periods, extremely heavy, not very much pain. So because of that, I ended up going on birth control. Um, when I was on birth control, I then started to experience IBS symptoms. So bloating, digestive symptoms, nausea. Doctors always dismissed it, saying that it was just my diet, anxiety, stress. So about 2 years ago, I decided to get off the birth control, and not long after, I started experiencing pelvic pain, extreme pain, pressure, a sharp stabbing pain, and a deep aching in like my ovary region that wouldn't go away. You eventually it spread to my chest, my lower back, and it felt like sometimes I was getting stabbed. Again, I saw doctor after doctor, and they each dismissed it. You're a girl, you're going to be experiencing these pains, they're just cramps. Um, but I knew something was wrong, and Bailey knew something was
Mhm.
wrong as well. Eventually, I ended up doing a ultrasound, and they discovered cysts in my ovaries. Um, and that was when we both decided that we were going to go through surgery. Um, and on surgery day, I was terrified, but ultimately they found a number of lesions, endometriomas,
Mhm.
um, and they were able to clear everything out.
And the cyst, you forgot the cyst.
Oh yeah, can't forget the cyst.
I had two massive cysts, and I thought to myself when they showed us, I was like, how were these cysts in my tiny sister's body? I just could not believe it.
It's
Um,
wild, right? It's
it was wild.
those cysts can be and still fit in the belly, right? But
Yeah.
Yeah. And it was interesting to see since we had it on the same day. I'm 2 years older than her, and I chose not to use birth control, but I had stage 3 and she had stage 4. So,
hmm
yeah, it was kind of like a little case study in the moment to kind of see how
For sure.
the disease might present differently in people that are obviously very genetically similar.
hmm
yeah, and we don't know, Devin, right? Like we don't know when you went on birth control at the time if you had those endometrioma cysts then, right? We
Yeah.
don't know kind of back in
No.
time. It's hard to know those things if we're not really having ultrasounds every year. So so
Exactly.
those are interesting questions is whether they were there, for a while or whether those came
For sure.
about after you stopped the birth control. It's interesting.
For sure. And I didn't really necessarily have period pains. My cramping it felt normal. It wasn't, comparing to Bailey, she was throwing up, you know, um, almost fainting at times because of her pain. And mine was just, another period. I didn't even have to take any medication to, nullify that pain. So just seeing the difference in how extreme mine was compared to Bailey's and how she went through all that pain, and mine was just, I thought I had IBS.
Yeah. Yeah, it's a great point. There's no Dr. Marcus and I talk about this all the time. There's no correlation between the amount of pain and the amount of endo we see. And
Mhm.
even with the best imaging, we always go in, right, Dr. Marcus, and we're like, well, we'll see what we find. And there's always a lot of surprises, right? We never know how many lesions we're going to see. Even with the best imaging, it's not perfect, right? And some of this disease is so small that you can't possibly predict all of the spots ahead of time. Your symptoms are a very good map for us, but
Mhm.
it's hard to really predict how many we will find when we're in there, you know?
And
Right.
I think that's a really good point because unlike there's so many things as a general surgeon, we see, I just actually came now from doing an emergent gallbladder surgery. So that's very definitive. Someone has pain, they come in, they get worked up, we do surgery, end of story. But it's touted that women may see 8 to 10 physicians before they get a definitive treatment of their endometriosis. And part of it is because of this reason. It's discounted a lot. And we really are um, we're not very good at assessing the extent of the endo. And unless you have a real collective sense by all the people that work together about and the history and the experience to know that it can be much more extensive than you might think. And sometimes it's less extensive than you think. So really the definitive workup is it's really an art. I would say it's really much more complicated than just getting an image. And that's why we all who are passionate about it, approach it this way.
Absolutely. And um, Dr. Marcus, do you want to talk a little bit about kind of how you approach this in the OR and what, how we kind of like start the case and what we do with the bowel, things like that?
Yeah, so I think it's interesting, even so I just spoke to a patient recently and the issue is even within the GYN community, or I would say not even in the GYN community, there are lots of gynecologists who really don't believe endo is a real thing. So that is, and many, many women, maybe, the two here who are nodding their head, yes, we recognize that there is sometimes a discounting, which is why that term of 8 to 10 physicians is there. We have evolved, and even within, so that's one thing. Then you go into the world of endo specialists, and even within that, there are, the ablation people and the excision people. And so I think that I've always been believing that the amount that we can see when we go in robotically, and robotic surgery is really a game changer, even over laparoscopy, because of the detail of the technology. We can see, I teach the residents, every day about how different the visualization and treating endo is all about being able to see and see well. And so our approach, and there's even some gynecologists who will say, I'll have a general surgeon on standby. I'll have their bat phone and I'll call them if there seems to be a problem. We've always felt that it is very synergistic and complementary to have both of us together. Both of us together are much better than both of us added separately. It's really a very, like I use the term as a ballet, it's really a dance. And we are committed from the moment we meet you to the moment we never say goodbye. So from the moment we meet you, but in the operating room, we're there together throughout the procedure because we don't know what to expect. And we don't know, there may be times where uh, we have to do some lysis of adhesions, taking down some scar tissue so that the endo can be addressed by Dr. Goldstein. So we might say, you know what, it's better for me to maybe address this part. And it's always a discussion. There's always two of us who are really bringing in all the wealth of our experience to try to do the best thing. And there may be times where we find things that we weren't even expecting. We may find a hernia. We may find something that we had no idea. The very first endo patient I ever did had a right inguinal hernia that we had no idea. And so we may think about those things later. We talk about the appendix, which we'll get into maybe a little bit later, but there are some targets, I would say, there are some issues with endo that we don't really think about normally, but we know that there's involvement. The appendix, we know statistically, is involved in about 30% of the time. And so we address that. So it's really a complete survey and a complete treatment. We may see endo up on the diaphragm, up near the lungs, and people think, what does that have to do with anything? I have no problems breathing, but we may find, and we do a very thorough search, and there's very special techniques to amplifying the visualization, whether we do a tumescent injection, methylene blue, or whatever. There's lots of different things. And so all of that together, I think just the amount of findings that we can see are really impressive. And we can't always know. We don't know about the appendix necessarily until the pathologists tell us, or even about the endo. So it's really important for us to be completely thorough, because at the point where someone has committed to go through this, um, like Bailey and Devin, it's really a big commitment. And so we want to be complete. We want to be as close to the right treatment for the right experience and for the right outcomes. So I would say that's our whole journey the whole time.
Yeah, absolutely. And I think, we get this question a lot about the appendix, for instance, is like they've had so many CAT scans in the ER and imaging, and their appendix was always normal. And so they're always shocked to find out it doesn't look normal on imaging, or it doesn't look normal to us in the OR. And I mean, I can't say how many times I rarely see on an endo patient a normal appendix, honestly. Like I rarely see one that looks like it's doing nothing wrong there, And I mean, I think the amount of times that we see it attached to the bowel, to the pelvic sidewall, to the psoas muscle, and that patient's been having right hip pain, and then we find the appendix wrapped around the psoas muscle. I think even when we find that that pathology is normal and doesn't say endo, there was some inflammation, some appendicitis, something that caused it to be attached there in the first place, right, Dr. Marcus? And it's not an appendix you would leave if there's something abnormal about it. And it always brings into the question that when we see 30% are abnormal, even on the ones that look normal, it's really hard sometimes to even look at any of them and leave them behind when we know that occurrence rate for an endo patient. And we know all the nausea, the bloating, the bowel symptoms that are involved with it, right?
Yeah. And there's different approaches, that's why we're believers in this excision, approach rather than just ablation, because, fulgurating or burning, first of all, it doesn't sound that it's that good to do that anyway, but, we find that we at least then have something real. We have something, if you're an ablation and not to discount, I mean, people who have good results with ablation, I can't criticize people who have good results with what they do. However, it's really complete trust. If someone does ablation, they're the only one in the world who knows what they saw, because there's no proof. There might be
Right.
a picture, but and it's not for legal reasons. It's just for treatment reasons. When we do endo, we might have 10 specimens, examples, excisions that the pathologist can look at, and we can know definitively there was endo there or there wasn't. And so I think that's really a critical, it's not only reassuring for us, it's reassuring for the collective us, meaning the patients who are the most important part, but we can really say definitively what the extent of that is. And it helps, nothing is 100%, and there are always some patients where there may be some recurrence of symptoms in the future. And if we don't have our baseline information, then that's really makes it much more difficult down the line. So I think that's another great reason to do what we do.
Mhm. Absolutely. And when you guys were looking at Devin and Bailey, when you were looking up sort of surgery and everything, you probably looked up excision versus ablation, and you had like a little discovery mission, right? Before you really booked
Yes.
surgery and everything, right?
I was I was definitely concerned about recurrence rates and wanting to make sure that if I'm going to go through with surgery of any kind, that it's going to be as efficient and, have the best outcome. So, yeah, there's definitely some differences in terms of um, potential outcomes with recurrence.
Yeah, and I would say often, when we talk about those ablation procedures, I see patients that have those every year or every 2 years or something like that. And we're really hoping, when Dr. Marcus and I go in there and we do these surgeries, we're really hoping that, we take that anesthesia risk and that surgery risk very seriously for you guys. And it's like we want the most thorough look at everything we can do, and it's like I explain to patients all the time. We do a camera inside the bladder, we put green dye in the bladder, we look in the uterus, we look in the vagina, we look in the abdomen. We're really sort of trying to look everywhere so that it's not all these broken up procedures where we might miss something, right? And because this disease can kind of go all over the place, we really have to be thorough for every case and not just be like, oh, well, this one may only have early stage disease, so I'm not going to do all those other looks and checks. We try to approach this sort of very much like having a checklist, like a pilot would, of like, okay, we've got to do this, we've got to do this, we've got to check the sigmoid colon, we've got to mobilize the bowel, we've got to look at the appendix, we've got to check this area of the pelvis, and I think that way we're hopefully not missing any of the areas. Um, and certainly, I think all of your symptoms always create a great map for surgeons to find endo. And you guys are better at painting the picture than any imaging can really. And it's, when we look back at everybody's reported symptoms and then what we find in the OR, it's so often exactly on the mark of where you said something happened. Like this hip locks when this happens, and this, leg pain happens, but only down onto my left thigh. And this, and all of those things are like really sort of like a map of the stars of where this can be sitting, and those symptoms are not for they're not for no reason. They're happening for a certain stimulus that's happening. Um, and let's talk about a little bit about kind of how your two cases were different. Dr. Marcus, we were talking about earlier about how one involved the appendix, right? And one had bilateral cysts on the ovaries and deep disease in the ovaries and kind of pelvic sidewall, right? And we think of appendiceal disease as a multi-organ spread, right? So it's interesting, the shape of how endo appeared for both of you. Um, so, and I think we did, let me pull this right here. For the, I think a lot of patients, Dr. Marcus often asks too, like, is it necessary to have the colonoscopy ahead of time? Is it necessary to have an MRI ahead of time? We were talking about earlier a little bit about endo mapping and doing, mapping of the colon ahead of time. Can you share with us some thoughts on that?
Yeah. So I think that it's not clear. I think let's just say the ultimate mapping is having a look inside the abdomen. The ultimate mapping is using a robotic resolution. Often when we should just take a pause and talk about what robotic surgery means, because a lot of people think that term means that something else is doing the surgery, that there's like, it's like lost in space and there's a robot that's doing the surgery. So just to be clear, it's robotic assisted and it's laparoscopic, minimally invasive. All these terms are sort of interchangeable. Robotics is really just sort of next gen visualization of technology for laparoscopic surgery. The ability to have HD, 3D, 10 times magnified is a game changer. There's no question that I really don't like when I don't have the robot available and I have to do a laparoscopic, even an appendectomy, because you just recognize how much better the visualization is. So robotics, as far as mapping, I'd say the ultimate way of surveilling the anatomy is with robotic visualization. So that's one. Some people talk about mapping, doing preoperative mapping so that we can either by ultrasounds, pelvic or rectal, ultrasound to see if we can map out. I'm not sure that it's very cachet to do that. A lot of people are using that as sort of a marketing. I'm not sure that mapping changes much unless there are symptoms that really direct us. And I think that's the thing. I will say two things that might seem like they're in contradiction to each other. I'll say that we have to follow the symptoms, and yet we don't have to only assume that the symptoms are what drive us, because Devin and Bailey are perfect examples of, we really anticipated that one was going to have worse endo, and it turned out that it was maybe the opposite. We found, more severe endo in one of you, and I won't say who, were more symptomatic and had more endo. And so that's kind of interesting. And the appendix, I mean, both of you had endo on the appendix. One was just a cystic structure that said endo. The other was endo on the appendix. So it was very interesting. I mean, that was, sort of now you might say, well, maybe there is a correlation because you're tied, you're related to each other, and so there maybe is, and we would expect that there's some genetic contribution to that. So that's not a giant surprise. But That's what I'll say. I'll say that, we often, no matter how many years and how many cases we do these things, I think, which is one of the things for me personally that's refreshing and stimulating about surgery, is that a day doesn't go by that I don't see something that I haven't seen before,
Mm.
which is very refreshing. I always think about, I trained in New York and I would drive across the George Washington Bridge. And, if I had to be a toll booth operator, I think I wouldn't survive very long. But being a surgeon where every day is stimulating is fascinating. And dealing with, there's nothing more satisfying than helping patients, women who have something that we can really see a change. And so that's what I'll say about that. That's a little bit off topic from what you were asking as far as the mapping, but I think it's,
Yeah.
call it emotional mapping, total
Yeah.
body wellness, all these things are good.
Yeah. No, and I think it's true. It's sort of like I always tell patients, it's like hide and seek. Like or the big reveal, like the surgery day is sort of like the big reveal. Like we never know exactly what we're going to find in there. And I know there's a lot of recent talk online like, oh, well, you can know exactly before you go in. And yeah, that's what we're kind of speaking to here is even the best imaging and best trained sonographer and look, I had a patient I saw today with proven bowel disease on a prior surgery. I didn't have pictures of, but I had multiple MRIs to prove it and surgical reports. And I did ultrasound of the upper vagina, the rectum, rectovaginal exam, and still, you know, I think it's not there, it's still not a perfect system for, and where her disease is on the bowels is higher up on the bowel, sigmoid colon and attached to the uterus. And even her colonoscopy, they couldn't even complete a colonoscopy. The bowel's so kinked, and it's still, we may have a certain idea in mind before we go into that surgery. But either way, you're right, Dr. Marcus, it doesn't really change the fact that we're going to do a bowel prep, we're going to do an antibiotic prep, we're going to get ready for the case, have the right team, be prepared in case there needs to be a bowel resection. Like all of those steps are going to be super important. And there's no imaging that's a diagnosis. Imaging is sort of we have a strong suspicion, but we don't have a diagnosis based on imaging. Endometriosis can only be diagnosed through excising the disease and submitting it for microscopic analysis. And they actually look under a microscope and they look for endometrial glands, endometrial stroma, inflammatory cells, and they compile that as a diagnosis. And so, all of these things that we do ahead of time are really nothing compared to what you can see with your eye and with the robotic camera, right? And what Dr. Marcus is saying is true is like, what we use the robotic platform for, the robotic camera is really great in that the camera is held, it's super steady. We control it with our feet, meaning we can zoom in on one little area that's maybe 1 millimeter and bring it up into such fine focus. And we can see things. Sometimes we're so zoomed in the surgery, like when we get out and we actually look at how small the specimens are, we're like, whoa, that's much smaller than what we were looking at on the screen. It's like you're in, Super Mario Land or something, and you're zooming in on everything. So it's always funny to sort of look at the actual size of the specimens. But yeah, that's very important with the visualization.
And I think that's a really good point that we talk about all the time is I always use the metaphor of like the little engine that could. Endometriosis is since it's partially hormonally, chemically mediated, the impact and the symptoms are often far beyond the actual size of the endometriosis. So
Mhm.
it's like pepper on steroids. You can have just a little it's like the Scoville unit of spice. You can have just a little bit really cause a lot of symptoms. And so
Mhm.
I think that's a misconception. Even, I talk to friends, colleagues who are gynecologists, and they'll say they did a laparoscopy and they saw a couple little black dots and they just zapped it, but that certainly can't be the cause of symptoms. And they just sort of ignore it because of that. But yes, I mean, I think it's really true about how much impact even a little bit of endo can have.
Yeah, I just saw a post up today that maybe we took 15 spots and one or two came positive. And she said, to be honest, I don't really care that only one or two came positive. She said she already has more energy. She's 5 weeks post-op. She has more energy. Her psoriasis is gone. Her bowel movements are getting better. And like it's like we can't quantify how little or how much something is and how it's going to affect them. And it's sort of it's irrelevant. I said it doesn't even matter how much they said. It's like the fact that you feel better is awesome. That's the goal, right? Is to restore the anatomy and then see what happens afterwards, right? And we know that just like Dr. Marcus is saying, it's like something is the size of a pimple or a sty in your eye and it still causes terrible pain and it's a nuisance, you know? So um, let's talk about Devin and Bailey a little bit more about your symptoms and kind of where it was found, and maybe about if you want to share a little bit about recovery or how things have changed, if you can.
Most
You want to go?
definitely. Yeah. So my symptoms really consisted of, kind of to generalize it, IBS symptoms, when I ate certain foods, I would bloat, and my bloating consists of every single day, I looked like something was going on. That and, that pelvic pain. I would eat certain foods and then I would feel a sharp pain where my ovaries were. And I mean, I think what they found, I had endo on my appendix. That really correlates to, the bloating and the nausea aspect of it.
In your chest too, right? Didn't you?
Yes, I did have chest pain as well. I believe it spread a little bit, or there was a leak up
Yeah.
towards my diaphragm. And, my symptoms, I mean, I did have lots of symptoms, but in the end, my pain wasn't as severe as Bailey's, I would say. I did have, more so it was uncomfortable and the bloating. And then when I did have eat certain foods, that's when I would experience a little bit of pain. But my periods, they were just a typical period. I mean, Bailey can
Well, I
speak
thought
on.
it was interesting with Devin. And I don't know, mine was, I had stage 3, so I not to say it's not an interesting case, but for Devin specifically, when we were discussing getting surgery, she would tell me, she had pain in her chest, she had pain on her side, and that is what they found in surgery, which is just kind of crazy that you can be that in tune with it and kind of that will show in surgery. I think you had
Hmm.
splattering from your cysts. It's funny, I know this is so older sister thing. I know her.
I know. I'm like, you
All
can
the
speak for me.
Devin's like, what did I have again?
you're her map. You're her
Well,
map.
yeah, yeah.
I mean, the going out of it, everyone was explaining to me exactly what was going on, and I was so out of it, In the end, I knew I had endometriosis and it was severe. So,
Yeah. I mean, and to your, I think you guys were discussing a little bit too, like symptoms are helpful to paint a picture, but they don't really paint the whole picture even at times. I know that when we went to surgery, Devin went in first and, I was waiting up next and I expected her to get done within, I think, 2 hours. I forget the timeline, but, hour after hour went by and they had to work on her surgery a lot longer than we expected. And so, and mine was very quick.
Mhm.
So, and imaging is just, in my opinion, as a patient, was not very accurate to what was really going on the inside. I had nothing show up in my transvaginal or my abdominal ultrasounds. I think Devin, they saw a little bit of cysts, right, in your
In my
ultrasound.
in my ovaries, I had two, I think it was chocolate cysts. Um, and then once they opened me up, I had more than just a few, very large ones. But yeah, thank goodness for that surgery. But
Yeah.
to go over a little bit over that recovery, so going back to what I was saying earlier about, my symptoms, the bloating for the most part it went away. After my surgery, however, I was still experiencing, my chest pains. My period would come around and I still kind of experienced a little bit of that pelvic pain. After going through that recovering and taking that time to really take care of myself, it has, you know, my my symptoms have nullified a little bit, I would say, but I'm still dealing with those symptoms, but
It's a process.
it is a process. You have to give yourself grace and take it day by day.
Yeah, my recovery, my first few cycles, I just kind of noticed a little bit of change in terms of the blood, what it looked like, my pain. But my most recent cycle, I had a completely pain-free cycle, which was crazy. I didn't even know that I was bleeding on my period, which is just not the typical case for me. So, I mean, it took a few months, but that's how it is. Everyone's different, even sisters with the same disease. It's just case by case, and you never really know how people are going to, what kind of disease, what level of disease, where it is in their body, and then also how they're going to recover.
Right. And we learned, right? It's like recovery is happens in stages and depends on how active you get and too active and too much. And it does take a minute. And the first few cycles can be more painful. They can be heavier after surgery. Some patients report they are heavier, but they're not as painful. It really depends. And it's very hard to predict how every single person is going to react. We kind of can make generalizations, but we have no idea how one person responds to the next person, and I think it really depends on what you're doing in life and work and travel and how much you're doing and what you're eating and the stress and everything that you're doing through recovery. So those things are all important. And I think nutrition, we had someone asking earlier about flax seeds and different things. I mean, I think nutrition plays a huge role with endometriosis. And I always like to, if there's still bowel symptoms happening and things going on, involve nutritionists who are really experienced with endometriosis because they can really help tease through, different foods that can help you, different foods that may be more difficult to tolerate, probiotics, digestive enzymes, things to kind of help absorb more and fiber and different things like that. We had someone asking about flax seeds earlier. I would say with endometriosis, in general, we try to avoid phytoestrogens or things that stimulate more estrogen, and a low inflammatory diet, but that looks different for every patient. And so we really kind of take that on a case by case scenario with patients and with a nutritionist that it really depends on your food sensitivities, what makes you react, what kind of protein you're taking in. And so this is really, it's hard to generalize. And I don't think for most endo patients that there's one endo diet and one way of eating and 5 foods that you should definitely eat and avoid and things like that. I think it really differs depending on the patient, I think it's
Yeah,
right, Dr. Marcus?
yeah, I would agree 100%. And it's not just endo. Um, I think it's unfortunate sometimes when people restrict themselves because of one particular entity and actually kind of don't enjoy some of their life as much because of that. People who have SIBO and they go on a FODMAP diet, for instance,
Mhm.
it's very hard for us. I mean, it's very easy for people who are giving advice to make it make sense because if you think of, oh, this makes sense because it's an anti-inflammatory, so an inflammatory process has to benefit from it. But, unfortunately, our bodies just aren't that simple. And so there's a lot of overlap. I think that there's nothing wrong with trying some things. And if people notice like, oh, I went gluten-free and suddenly I feel better. But I think the problem is on an individual basis, that's okay. It's just very hard to extrapolate that to generalize that so that you can use that same advice for everybody.
Mhm.
So again, it gets back to everything tailored for individual, nothing wrong with trying. I pride myself on not being rigid as just a Western, healthcare person. If acupuncture seems to work or anything, then we're all for a multidisciplinary approach to everything. And I think that's important. But I would just caution people to not drink the Kool-Aid of one particular thing and especially when it's great to have surgery for endometriosis when you get to that point where it seems to be the appropriate thing. And then maybe just peel off all the other things, and then you will at least know what was the result and benefit of the endo excision. If you have a million different band-aids, you're never going to know what's working. So I
Right.
think that's a really important thing. And then as we counsel and caution women that the first couple of months they may have a more painful period than they did before surgery, but just as time goes on and it's a little bit different for everyone, see where the dust settles and then you can reintroduce maybe these other things. I'd say that's the same thing for pain medication. I'm a firm believer in, EROS, enhanced recovery after surgery, and we've really in an era where we try to minimize or absolutely eliminate narcotics as a pain regimen because there's so many things that we can do. So all of those things together, I think we always are learning, we're always trying to adjust and reassess how the theory of minimally invasive is about treatment. We try to do as little as possible with the maximum gain. And that's on my bumper sticker, least invasive, maximum results. And
Yeah.
so that's really translates to everything we do.
Yeah, absolutely. And I think it's important to sort of always keep that in mind. And I think you're right. I think it's hard, and I think, patients can be sort of driven nuts by doing like the FODMAP, the gluten-free, the dairy-free. They've given up like everything, and it's like, and know this and know that and know, and I'm like, oh man, what exactly are you eating? And it's really hard. So I think anytime there's something like that going on, I love to get a nutritionist involved just to make sure that there's really enough nutrients and that we're not giving up so many things like you're saying and then there's always, good old sort of like reintroduction diets and allergy diets on how you just like take a few days to reintroduce one food and see if you really have a reaction to it and if that's really necessary or not. And so I used to work for an allergist years ago, and that's what they do on like a 3-day cycle of reintroducing that food. And so there's things like that that can be done. Someone's asking how SIBO and endo correlate, and are the symptoms the same? Were either of you guys diagnosed with SIBO ahead of your endo surgery? Did
No.
anyone do that? No? Okay. Dr. Marcus, what do you think about SIBO and Xifaxan and endometriosis and
So I
the
think, we always talk about the potential correlates with endometriosis. And, the big five are, SIBO, IC, interstitial cystitis with bladder infections, infertility issues, and painful periods. Those are sort of, I think that was four. But I think, so though, but those are very broad spectrum, and especially when you get to the GI symptoms. I don't think that there's a direct cause and effect necessarily of endo and SIBO. We do see an increase frequency in women or incidence in women who have endometriosis with SIBO, but I'm not sure that it is exactly the same. So again, I think that, people who are tested for SIBO, they might go through Xifaxan and other treatments and FODMAP diets, and I'd say the same thing. It's important to recognize what might be contributed, and that after surgery, then you can begin to really see what is left. And if GI symptoms continue, then we can, counsel our GI specialists and see where we have to go. But I wouldn't throw everything at it. Just like, one other thing that I think is important is many women, and Devin and Bailey, you can comment on your own experience, but many, because of pain for a long time, they've been seeing pain management physicians for a long time. And we talk about this down regulation. And so we see some women who've been on Neurontin, or they've been on high dose pain medication for a very long time, and they are then having trouble weaning off afterwards, but they do it slowly. So we try, and I'd just like to know your opinion on that, Dr. Goldstein, what you think about the whole, because there are a lot of women who, we get to it and we have a hard time doing what I said before of minimizing narcotics because they've been on pain medication for
right.
so long that they are fearful of going cold turkey on that.
Yeah, and I think it's very hard in those cases. I mean, I always like to sort of tease out all of the medications and all of the supplements and like everything someone's doing ahead of surgery, because there's a lot of cross interaction and there's a lot of side effects from medication that often patients are not told before. And, even something people may seem as harmless. So, okay, let's do some vaginal Valium for pelvic floor therapy and to relax things. And I was told to do that for painful intercourse. They don't know that there's a lot of mucosal absorption in the vagina, and it's a great place to absorb a medication. And there is systemic absorption. I do see bowel dysfunction and bladder dysfunction from things like that. And systemic absorption, even though it may be on the vaginal mucosa, transdermal, even on the skin with hormone creams are a great way to absorb them. So, we know that all of these medications have a potential to have some kind of side effect. And like you were saying, Dr. Marcus, like the Neurontin, while it can relieve pain, it also has an effect on smooth muscle contraction and bowel movement and the bladder relaxation. And so, I do find in cases like that, and I do a transvaginal sonogram on almost everyone I see in the office. And I'm always checking, like they go and pee beforehand, and I'm always looking right off the bat at the bladder and to see if there's any urinary retention, if the bowel's kind of moving slower than usual when I'm looking at it, or if it's like whirling really fast. Sometimes they're on laxatives, but there's little clues that we can see even just looking at these things ahead of time. But I think a lot of people are not really told most of the side effects of the medications they're on, unfortunately. And you can look them up, and then when you look them up, it's sort of intimidating because you see 20 possible side effects, But the fact is that a lot of these medications have a few ones that are quite common. And like Dr. Marcus was saying, the opioids and the Neurontin and a lot of the pain meds, while they may help with pain, unfortunately, the way they're designed and the way they work is that it sort of keeps dulling the pain receptor and you keep needing more and more to be effective. And then it does have a lot more reaction on the resultant bowel and bladder function and systemic function. And so it is hard to sort of tease all of those out with patients. And it may take a long time to sort of down-regulate all of that. And I think there's a lot more creative options right now. I like to do, different things to sort of combat that and work through those medications. But I think it's a tricky business, and it's tricky when, patients are sort of not given all of the upfront information about all of those.
That's really so well put. And I think it's also difficult because there is a dependency and an expectation that pain before surgery, let's say, is managed to a degree by a lot of other treatments. And so having that leap of faith or believing that it can possibly get resolved without those medications afterwards, I think is, challenging for some. I think it's very refreshing because most women will find afterwards that they really don't need that. And, let's face it, I mean, Neurontin and those medications, besides slowing the gut and everything else, Neurontin, many people feel very foggy from it. They really don't realize how much it affects their clarity until they get off of it. And they say, oh my gosh, I was really in a fog. So, those things are, I think, all really important. And we have so many good alternatives now. There's drugs like Journavx or other drugs that have zero narcotic effect that we can affect. But for the most part, the surgery itself, and Bailey and Devin can speak to their experience. The surgery itself, from the incisions of the robotic trocars, the little tubes, is not so bad. Most people recover from that trauma from the surgery pretty quickly. Would you both say that? What can you talk about that a little bit?
Most definitely. I mean, I think it was the day after surgery we were up and walking. So I mean, we weren't exactly back to normal right away, but I mean, even just getting that surgery done and being able to stand up after is huge.
Right. Yeah, I think the recovery was not as bad as I thought. And I think there's certain things that you can do to help heal and just get your body moving was really helpful for us. We walked a lot. Trying to get the gas that is in you from surgery out is also really helpful because that can cause like sharp pains or not sharp pains, but just kind of pain and discomfort. Yeah, the surgery, the recovery wasn't bad at all. And I think I mean, not everyone goes into surgery with a sibling, but it is nice to have, whether it be like a broader endometriosis community online or someone that has gone through it, to just support you, but not as difficult as I thought it would be.
I think sometimes there's a disconnect between how small the incisions are and how big the surgery was inside, right? sometimes I mean, I really like to show you guys, I show patients the pictures and the videos because it's like to connect those dots of how massive it was inside. You know, the little incisions don't really do it justice. You know, it's not like, you know, it's like, and those may heal very quickly and you may still have some symptoms from the recovery, but it's always like, oh, but inside there was still a big disease and a massive surgery that happened, and it's just these tiny little things that healed quickly, but it's not the same as everything that was happening inside, right? And we
Mhm.
may spend like, you know, Dr. Marcus and I may spend 5 hours on one case, and then those little incisions, it's like it says it's no marker of what was going on inside for that whole case, you know? So,
We got the
wild,
footage, and the footage was
right?
really
That
interesting
was
to see.
that
Yeah,
was the evidence.
the evidence that
Yeah,
something
exactly.
definitely.
The other thing that we do that I did on with both of you and on every patient is we do this thing called a TAP block, which is a short acronym for transverse abdominis plane, which is a field block of longer acting anesthetic, which we do while you're asleep. And that's sort of think of it like a block anesthetic to the abdominal wall. And so that really helps mitigate a lot of the pain that, patients feel afterwards. So it's hard to know how you felt about that, but if we think about how the pain was, that usually lasts for about 18 hours. So that's one of many tools that we have to sort of blunt the immediate post-op, discomfort.
Mhm.
Mhm.
There's
And some people are asking what stage endo. They had stage 3, 4 endo we discussed. And I think, you know, Bailey, you had endo on the ovaries, even though the ultrasounds were negative ahead of time and the MRI and things like that, there were still ovarian implants on the surface, which could then become deeper. So I do think that it's always very important that, you know, this is really a deep search and not, you know, and we can't always take away everything from the imaging, right?
Mhm.
So, you know, what would be some of you guys' top sort of tips or tricks for recovery for patients or for bowel symptoms that you guys have kind of learned through this process?
Heating pads are your friends. Heating pads and immediately after surgery, I mean not immediately. You have to give yourself grace, but getting up and walking, I know
Mhm.
it sounds intimidating and you don't want to do it, but it really does help.
Yeah, walking. Trying to think what else really helped us. There's especially when having surgery in your abdomen area, it's a little bit difficult or uncomfortable to sit up. So maybe when you're in bed, having one of those block pillows that keep you elevated, just so it's easier to get in and out of bed.
Mhm.
Um, that was helpful as well, just because it's like we were talking about earlier, tiny incisions, but there definitely was a lot going
Yeah.
on in there. So you definitely still need to be gentle with yourself. But I found that was helpful is being propped up because you're going to be in bed a lot and getting in and out of bed can be a little uncomfortable initially.
Yeah. Okay, perfect. And, you know, we definitely have some more questions and some patients doing some specific case questions, which we'll get into later. We're always happy to do case review. Someone's asking about, you know, hysterectomy and ovary left behind, and is it possible for postmenopausal endo? I mean, I think it's a great question, and that can be a whole nother topic. But yes, postmenopausal endometriosis is definitely possible. And if there's an ovary left behind and there's hormone replacement done, there's definitely a possibility for further disease or lesions there. So we're always happy to do case reviews. If you guys send information after, and Cassie, our marketing director, can reach out and give some ways to get a case review. So for everybody watching, um, and we appreciate all of you being here. It was a fantastic discussion, and I'm trying to think, Dr. Marcus, do you have any more last minute tidbits we forgot to talk about?
I feel we were pretty thorough. I think it was pretty complete. I mean, it was fantastic having both Bailey and Devin because that's the real, we could talk and talk and talk, but you are really the channelers for all of this, being able to um, make in real experience what we're talking about. And so, I think it's great. There's lots more to talk about. We could talk for a long time about different elements. But no, I think we covered a lot of ground, and I think there were a lot of fantastic questions which we can continue to look at.
Yeah, we're happy to respond, guys. We'll be doing some top questions on email response for you guys later. So if you keep sending them in. We'll go through them. And I think a big thing that, we heard from Devin too is that, symptoms like IBS, if you're sort of being dismissed, or IBS or SIBO, if you've been kind of given any of these diagnoses, ulcerative, interstitial cystitis or bladder issues that aren't going away, and you suspect it may be endometriosis, there are a lot of diseases like that or entities that patients are told. And then if you're finding that the therapies are not really working for them, we sometimes see this, Dr. Marcus and I see this even with irritable bowel disease. The therapies aren't working and they seem to have a strong hormonal component, like stronger when you're ovulating or stronger around the period or right before the period, then there may be a strong chance that that's endometriosis related. And it's always a good idea to have a little, visit or consult to see if that is possible. And so I think that a lot of patients, when their primary focus isn't just the period, they may be given, a sort of turn away from endometriosis or say that it's not important, or birth control will fix it, or IVF will fix it, or menopause will fix it, or pregnancy will fix it. But every day we see that, I see patients that get worse after pregnancy, patients that get worse even after menopause. I see, all different situations. And so, like Dr. Marcus is saying, that every patient's endo story is totally unique, and there's all different ways this occurs, and we can't really be blind to it. We just have to like sort of tease out all the symptoms and all the places it can be. So, despite normal imaging, what we talked about earlier is that we can always find extensive disease even with totally normal imaging. And so imaging is not perfect. Your story is the best thing that we have ahead of surgery. I have a PA here in New York that prints out my story for everybody's story and actually pastes them onto the robot for me. And I check it all through the case to make sure that I've seen all the spots that maybe those symptoms led to. And it's really important, and that is the best map for us, right? And so I think that, trusting your patients, listening to your patients, really taking the time with them, and having you guys' map and everything you go through is so, so important. So, okay.
Most
Great.
definitely.
Thank you so much for everybody coming on. We're going to get kicked off in a couple minutes. I'll see if we have any more last minute things we can answer quickly. Let's see. Um, Everybody loves seeing sisters with on the social, guys. You're famous.
Yeah, I would just say trust in yourself. It's really easy to get dismissed and to think you're crazy because doctors don't believe that it could be something more serious. But I'm really glad that I trusted, my intuition, and Devin trusted, and we, are now feeling a lot better. So
No,
trust in your
definitely.
intuition.
And there's, it could feel discouraging when people kind of dismiss your symptoms and, you don't feel like you're heard, but there is a community out there. I know that they mentioned you guys can email them, but also if you guys are experiencing similar symptoms, you're more than welcome to shoot me DM daily too. But I just wanted to say thank you guys for,
Thank you for having us.
letting us share our story, and hopefully you guys kind of,
Take something from it.
exactly.
Absolutely. Well, thank you so much, all of you.
Thank you.
Thank you.
Dr. Marcus, are you back off to another surgery?
Soon, yes.
Yeah. Okay.
Good luck.
Still daylight here, so we have some more time.
I know. We can't tell with the pink background, but you guys have some more daylight hours. It's very dark in New York already. So it's full fall here. So. All right. Well, everyone have a lovely afternoon and evening, and thank you so much. And we